Hello and welcome to your monthly update for our practice group network. My name is Alex Bardakh. I'm the Director of Public Policy and Advocacy at AMDA, the Society for Post-Acute and Long-Term Care Medicine. I wanted to provide this update because there's been a lot going on over this past month as we're getting through the summer months. July is usually known for the 4th of July and the holiday. But in the Medicare physician world, it's also known for the release of the annual physician fee schedule proposed rule. And of course, it was released this month, and there's a lot to cover within the physician fee schedule. To start with, I think there's some good news on the front of the nursing facility family of codes. We've been talking about this for quite some time, that AMDA has been engaged in revisions to the nursing home family of codes through the what's known as the CPT RUC process. CPT, of course, is the American Medical Association's coding structure. And then the RUC process is where the codes get valued, and then CMS reviews those values and proposes them in this way of rulemaking. So AMDA has provided an overview of what the actual numbers are, but just to give you a quick overview, CMS accepted the RUC recommended values that AMDA had worked on over this last year, and majority of the codes see a substantial increase in their work relative value units, which of course plays into the overall value of the code. So that is fantastic news. It is something we were hoping CMS would do, and they are proposing to do that. Now they are saying in the proposed rule that they want to hear from stakeholders whether or not those values should be finalized. They do have some concerns, but we believe those were valid and should move forward. We being AMDA, will work on a template, likely a letter that you can all send to CMS supporting what they have proposed in terms of the work RVUs. We urge you to submit comments. CMS does review them, and the more comments they receive in support of a proposed policy, the more likely it is to be finalized when the final rule is issued in November. So please stay tuned for us. Please let us know if you have any questions on that front. It is something that is extremely important, obviously, for the viability of practices and to recruit new practices into the fold, into the post-acute and long-term care medicine sphere. Now, some of that good news is offset a little bit by the overall proposal for the physician fee schedule. And overall, due to budget neutrality, CMS is proposing a cut to the what's known as the conversion factor. That is how they essentially figure out budget neutrality within the Medicare program. And that was to be expected. We knew that that is likely to come. And so some of the increases in the work RVUs of the nursing facility codes are mitigated by this cut to the conversion factor, but that is across the board for all CPT codes, whether they're primary care, surgery, and whatnot. So that is something that AMDA will be working with its partners within the family of medicine, within the quote unquote house of medicine. Congress has intervened many times when such cuts have been proposed. We expect to work with Congress once again to offset this conversion factor cut. And if that indeed happens, which we are hopeful that it will, if that indeed happens, then of course the nursing home codes will see even a greater increase overall because there won't be that cut within the conversion factor. So as I said, this is covered in a nice little table that we put out there within our new policy newsletter called the Spotlight. So feel free to go there and look at the overview. So that's some of the news on the sort of the big picture payment policy. There are other things that AMDA's been working on that we're hoping to work with the Practice Group Network as well. And that is that anecdotally, we are hearing that there are many practitioners, and namely physicians and advanced practice providers, that are leaving the field of post-acute and long-term care. And that is troubling. We hear that in some areas of the country, it is difficult to get physicians to go into facilities, to see patients. And of course, that's troubling news. It's not an issue that is well known, in my opinion, throughout the country, but it is something that we continuously hear. We have raised this with CMS, and it is certainly on their radar as well, because clearly, if we can't recruit new physicians out of residency or sustain a physician workforce or even advanced practice provider workforce for this field, it'll be troublesome. So, but some of the things that have been utilized to augment that is telehealth. And there's been some confusion around where telehealth stands at the moment. So just to be very clear on this, or as clear as possible, we are still operating under the public health emergency. It is scheduled to end on July 15th. If you're listening to this after, clearly it has been extended. It's been extended to by 90 days typically. So the next date that it may end would be October 15th. And there's a rule that the administration has to give 60-day notification if they are to end the public health emergency. So the date that you would be looking for that signal would be in August. But regardless of the public health emergency, CMS has also been ending some of the waivers, particularly in nursing homes. And the one around telehealth has probably caused the greatest confusion. CMS issued a memo, I talked about this before, on April 7th, that ended the physician, that ended the ability to bill the physician required visits via telehealth. That was in effect as of May 7th. Some folks have interpreted that the initial visit can still be billed via telehealth. At this point in time, and I stress that at this point in time, our interpretation is that, in reading the longstanding guidance, is that the initial visit, the 99304 to 99306, is a initial comprehensive required visit. And although it still appears on the telehealth list, you would actually have to apply for the waiver in order to be able to bill it via telehealth. So as of this moment, you are unable to use it. However, all other visits you can do without limitation. So if it's not one of the 30, 60, 90 required visits, you can do as many visits via telehealth as you want. There is no limitation that exists during the public health emergency. So again, that has caused some confusion. And if you are a practice that's utilized telehealth and is still billing for potentially initial visit codes, or have a different view, or have been told by a Medicare carrier, we've been told of one instance where that happened, something different, we'd love for you to let us know. We have notified CMS of this sort of confusion, and hopefully they will be issuing a clarification. We at AMDA, of course, regardless of the regulation, are continuing to have a discussion about what should be the role of telehealth moving forward. And we'd love to hear from the Practice Group Network about how you've utilized telehealth, what you view the role of telehealth would be in the future. Should initial comprehensive assessment be on the telehealth list moving forward? What kind of guardrails, if any, should we have around telehealth use in nursing homes? Is 100% telehealth use appropriate? Is some percentage of it appropriate? Should there be documentation requirements? Is it for certain areas of the country, rural areas, or is it should be everywhere? All of those sorts of things are something that we have been talking about extensively in developing policy, and we'd love to have the Practice Group Network involved in that conversation, because we realize that is important. A couple of other things really quickly. CMS issued its final rule for phase 3. If you recall, back in forever ago now at this point, but they issued the nursing home regulations were revised in these 3 phases. Well, the first two phases were in effect for quite some time. But the third phase, they had issued a proposed rule, but then during COVID, they never issued the final rule. So they finally did that earlier this month. It is important. It has more, of course, rules for facilities rather than for physician practices. And we have been covering that, but there are rules around part-time infection preventionists. There are rules around PRN antipsychotics, which is, of course, an issue that we've been tracking for quite some time. And CMS continues to be concerned on that issue about the incidence of diagnosis of schizophrenia in the nursing facilities. We had issued a statement a long time ago that facilities shouldn't be diagnosing patients in order to not be dinged for antipsychotic use, that the diagnosis should be based on proper evaluation of the patient, and in no instance should ever be done because of other reasons. But we continue to work on the issue and trying to work on the quality measure and ensure that appropriate use of antipsychotics is able to, that you have access to appropriate use of antipsychotics. But then again, that if it is used inappropriately, or if a diagnosis is changed inappropriately, all of those things are obviously not what we're looking for. So those are some of the quick highlights. There's a lot going on. We continue to do our work on transparency around the medical director. Again, that's more on the facility issue, but we've made some progress in our states. And so, we'll continue to work on that with Congress and with CMS to figure out a way around transparency around the medical director role as CMS is rolling out some of the changes that the administration had proposed. Those are some of the highlights for this month. Please, as always, stay engaged with us. Please read our monthly updates that we provide for the Practice Group Network. It is sort of a special group. We have a forum for you all to discuss between yourselves about the challenges you're facing for your post-acute long-term care practices. We know that there may be potentially many. As I said, there is some good news moving forward in terms of payment. And we'll continue to advocate on your behalf. And we hope that you stay engaged with us, ask questions, participate in these types of forums and these types of conversations. Thank you all, and hope everybody has a good rest of the summer.